Regeneration, and the D stands for discovery, discussion, discourse, debate, etc. Today is May 1st, and it's a momentous day always, and one where we historically have looked at changing things around, revolutions. And so today's topic, if I may make a long stretch there, fits into that theme. It's regenerative medicine. It's kind of looking at how to regenerate bone and cartilage in the treatment of spinal pathologies. Our visiting professor today is Dr. Benjamin Elder. He's an MD, PhD, and I'll introduce him in greater detail later. Professor of neurosurgery, orthopedics, and biomedical engineering at the Mayo Clinic. And he's also the program director for neurosurgery's residency program. We're very keen on hearing him talk about various adult reconstructive options and what's new and what's happening next, as we're still in this era of major reconstructive surgeries. To tee us off, we have Dr. Cliff Pierre here, one of our research fellows, and he has an interesting case in terms of a very common problem that revolves around degenerative disc disease. So, Cliff.
Okay. Again, thank you, Dr. Chapman, for that kind introduction. I'd like to get started. We have a 47-year-old female who had presented to us in our clinic with intractable low back pain and bilateral buttock pain that she had said had worsened for her over the last year and a half or so prior to presentation. She had tried conservative management with minimal relief. She's a nurse, and this pain significantly limited her activities. She has a history of psoriasis, no past surgical history. This is her motor exam and presentation. Some mild weakness in her hip flexors bilaterally, as well as hyporeflexia on exam and some decreased sensation. This is some of the management that she's tried conservatively prior to our presentation in clinic. And imaging, prior to our visit, here we have a flexion extension x-ray. Shows that everything is in good standing position. Significant degenerative disease in her lumbar spine, specifically at her L5-S1. Here is a CT myelogram of her lumbar spine. Again, showing that significant degenerative disease, vacuum disc at L5-S1 back in 2008. Again, we were able to get increased sensitivity with where her pain points were with respect to imaging. And this is an MRI lumbar spine of axial and sagittal view. Again, noting severe degenerative disease at L5-1 with modic changes at that disc space as well.
So this is a very, very common problem. And Cliff, so what do you make of this? How common is this, and when does this mean that this might represent pain? What do you remember in your own training to be a possible problem there?
Again, significant arthritic changes in the lumbar disc, commonly for patients. She's 50 years old. She's quite active, so I'd say probably 30 to 40% in her patient population. And we're seeing more and more in these in our clinic. They're showing up. Referrals from our pain management doctors, primary care, also refer these patients to us, so it is quite common.
So this is, here, come up front there, one of you guys. So this is a nurse, actually, and Cliff presented this patient. She's 47 years young, very active person, and she has severe back pain. She has a normal lumbar spine except for her L5-S1 disc, which is kind of worn out. How do we know that this is a painful disc? Is this a painful disc? How do we know that it's a painful disc?
Yeah. I mean, in my practice personally, I like to ask people about 4 things: sitting, standing, walking, lying down. And pain with flexion in particular, in the absence of claudication type symptoms, can be suggestive of a disc pathology. In this patient, you can also get, as timely you put up, the advanced imaging studies to show where there is reactivity.
Yes.
And so for this patient in a particularly active in an active patient without an unstable spine, with no abnormal curvature. This is one that you could consider for a disc arthroplasty.
So that's one of those things in terms of working up a back. I like how you did that, the 4 activity-based things. And again, in degenerative disc disease, sitting is the one activity that probably puts the most pressure on our discs. And
Yes.
That's a classic kind of discogenic back pain thing. And in terms of non-surgical care, Cliff, what do you recommend we do? What should we kind of think about doing as we see a patient like this?
Non-surgical care, first, we'd start with conservative management in the setting of physical therapy, seeing if strengthening her core could definitely reduce some of the pressure to her low back. You could, outside of oral medications and management in the setting of narcotics, muscle relaxants, but you can also attempt to do injection points to see specifically how improved her pain is and in which joints after these injections are done.
So yeah, so this is one of those things. The first thing I think we as surgeons should do is not jump to surgical care, but establish a relationship with the patient. Help guide non-surgical care with all the modalities, encourage patients to try to strengthen themselves, get mobility back, because there's not a catastrophic neurologic event happening. There's not a catastrophic structural threat looming in the background. This is a degenerative disc. It's a single-level degenerative disc. And this patient hopefully will respond to non-surgical care. And frequently patients require some encouragement to kind of get over that, because as we know, our back sends threat signals, and many patients in their brains see this as a existential threat for whatever reasons. Did you ever, as a neurosurgical trainee, figure out why that is? Why do some people have such a strong inclination towards responding unfavorably to back pain?
Not particularly. Why some are more predisposed to, having higher reactivity to their pain than others. And I think that's still to be determined. In our new environment, psychosocially, there's issues like that as well with respect to the responsiveness to some of the reactivity of pain.
Yeah, it's remarkable how some patients just really respond with a fright and flight response to back pain. And one of our jobs is to de-escalate that as much as possible.
Do we have Dr. Elder on or any of the other faculty members? Okay.
So this patient, what would you do there? Dr. Anderson just joined us, but Dr. Davis, you're going to be in charge of patients as of August 1st. What do you want to do?
I think for this patient with stated failure of conservative treatment, I think it's reasonable to do a disc arthroplasty on her.
So assuming that we've done an extensive non-surgical care with facet blocks, with well over half a year non-operative care, compliance of the patient, avoidance of regular opiate intake, and all that, and no major adverse claim issues that are still pending. A disc arthroplasty, what do you think about that, Cliff?
I think that's reasonable for her age as well, being a 47-year-old female, maintaining her mobility. I think that's a very reasonable approach, lowering her risk of any further problems. Always the discussion that she might need more surgery later, especially her active lifestyle. But yes, I think stabilization procedure, maintaining her motion preservation would be good in this.
Dr. Anderson, you have the microphone ready. So what would you suggest? You've established a good relationship with the patient. There's no objective neurologic damage.
Yeah, I agree. She has axial back pain. She has a obvious evidence of degeneration at that level.
Yes.
And she's quite young. So, given her age and her relatively otherwise normal medical history, this is going to be a problem at some point in the future. And I would like to restore function at this point, get her disc replacement.
So you think a disc replacement would be fine, yeah. And did you see the hot bone scan?
Say again?
We actually got a bone scan, and it shows a very clear activity increase.
Yeah.
And so with the scan here, the back pain can come from be facetogenic or discogenic, right?
Yes.
And we talked about facet ablations, et cetera. But what about basically vertebral nerve ablation and trying to figure out if it's coming from anterior versus posterior? Because once we replace the disc, facet joints are going to be way loaded.
Yeah.
So how do you distinguish that? Is there a way to do that, or?
I think these are things you can continue to discuss with a pain specialist. I know some of our co-fellows are going to be heading out to the Midwest and having a very comprehensive pain specialist to try all these modalities to distinguish which of the pain is more significant, whether it's disc versus facet, and then try these other alternative routes with respect to nerve ablation before subjecting her to a more invasive procedure like surgery.
So Dr. Randy Davis has a great point. One of you guys, can you talk about Intercept in patients with modic changes and this becoming a lucrative thing? What is Intercept and what are your thoughts on it? What have you seen?
Intercept is the basivertebral nerve ablation.
Yeah, no.
Yeah, so that we are sending patients to do that occasionally when we think that we want to distinguish between the two.
Yes.
Data on that we need to figure out yet. I think this is one of the new things that have come about, and our pain doctors do these procedures, so it'll be interesting to see the results for that.
Yes.
This patient actually had this problem many years ago, so this is way before basivertebral nerve ablation / Intercept was a factor. But in my era, we had something called IDET, intradiscal electrothermal therapy. That was the latest and greatest. We actually had a bunch of those patients at Harborview, and it was just the typical thing that there's some people who responded and a lot of people who didn't respond, and we didn't quite know what to make of it. We had a couple of people whose discs is literally disintegrated. But so the fascination with the disc itself remains unfettered. Now, the Intercept studies were actually done with Dr. Bernhard Meyer. He's a frequent lecturer here from the University of Munich, neurosurgery chair. So the results are, again, very compelling because it's the usual 2/3 of patients who seem to respond favorably and 1/3 who doesn't, and that's a number that pervades all aspects of spine care, including surgery. So what was done in this patient? We did not have basivertebral nerve ablation back then.
No, not at that
The concept
time.
is certainly interesting and one that I suggest everybody look into more, and we'll have to have a speaker on here, maybe Dr. Meyer. So what do we do?
So we proceeded, here's an intraoperative lumbar floral film, a sagittal and coronal. Here showing a lumbar total disc arthroplasty. Won't mention the device that we use, but you could definitely tell here in this setting. And she did quite well, actually. She remained very active until we saw her about 10 years follow-up with new symptoms, some worsening low back pain, bilateral leg pain at this point, ongoing for a year. Prior to seeing us in clinic, she was advised to wear a brace, and then also, again, tried multiple modalities with conservative management. Prior to presentation in our clinic, she saw Dr. David, one of our pain specialists, and found some relief with the injections at L4-5.
So what's the delta of her return presentation? She had the index procedure
10
in
years.
2009, 10 years later.
10 years later.
Good. So good morning, Dr. Elder. We introduced you briefly this morning already, and we're talking about osteobiologics. Thank you so much for joining us. It's great to have you. It's a great honor, and we're looking forward to your comments on biologics.
Yeah.
And Dr. Pierre just presented a patient with isolated L5S1 degenerative disc disease and otherwise normal-looking spine, a very active person.
Very
She
active.
works as a nurse.
Yep.
And we can just flash it up again with a hot bone scan. So this is just an appetizer for your talk later, but this is a hot bone scan. And I took care of this patient in 2009. And the rest of the MRI, if you go back to the MRI, looks pretty much normal, maybe not quite enough water signal. So we just talked about non-surgical care for a patient like this. What are your thoughts in terms of a surgeon like yourself seeing a patient with an isolated single-level degenerative disc disease with a positive modic change? No neurology.
Right. Yeah. So I think for dealing with back pain, that's always the challenge. So number one, making sure there's no instability and having upright x-rays and flexion extension views. And so you can see it looks like there's probably a bit of a vacuum sign in that disc as well.
Yes.
And I'm sure the CT would show that better. Doesn't look like there's too much of a spondylolisthesis, although there were some facet effusions. So I think that was L4-5 that looked worse. And so I think these end up somewhat challenging as the data is mixed on the benefits of stabilization surgery for this type of pattern. But I think in some of the patients where they have pretty clear pathology at that segment, then I think exploring surgery makes reasonable sense. I think I would certainly start with non-operative measures, looking at some of the facet-based interventions, radiofrequency ablations tend to have pretty good outcomes in these patients, physical therapy, and then pain control.
Dr. Randy Davis mentioned the Intercept basivertebral nerve ablation. Is that something you guys do at Mayo Clinic?
We have not done much of that here, but it does look like that's maybe a promising intervention.
So back then in 2009, we did not have that at all. We had IDET around, so sticking electrodes into the nuclei of patients and kind of burning the annulus down.
Yep.
So
we proceeded with the lumbar
disc
arthroplasty. 10 years later, now she represents to us back in clinic, again with some worsening low back pain, this time radiating to bilateral legs, it was a little lower than it had prior to presentation, 10 years prior. She's wearing a brace. She's tried conservative management. She actually seen our pain specialist. He did an L4-5 injection at the time, and she found it to be very helpful. Again, significant past medical history of psoriasis, and then here her disc that was done in 2009, and we sent her for a myelogram. And as you can note, significant myelographic block at L4-5, a severe spinal cord compression at that level. There's artifact, but the disc arthroplasty appears to be stable at this point. And then the level of spinal listhesis is a grade 2 in this setting as well. So again, just a summary, grade 2 spinal listhesis at L4-5 at the adjacent level, severe spinal cord compression.
And then how weak is she?
4 out of 5 bilaterally.
Gotcha. I mean, and so she's already done the conservative treatment. And so I think surgery is reasonable. I'd want to see if there's still motion at that L5-S1 arthroplasty. If it's stiff, I'd probably include that in a construct within the surgical treatment. But if it's still mobile, I'd probably just do a one level TLEF above there. If it's not mobile, I think it would be helpful to have a little more fixation, as these tend to fail by the distal fixation pulling out. So probably go down to S1 in that case to have a little more support.
So I thought this was interesting because we did a disc replacement explicitly to try to minimize adjacent segment. And here, 10 years later, this patient who has psoriatic arthritis, but she's, I don't know what antibody therapy she's on.
Yeah, she's on TAZ.
Okay.
Yeah.
But she's been extremely functional throughout all these years, and again, very, very active. Mm-hmm. So this is kind of disappointing to see. Disc replacements, is this something you do? Is this something that's truly better in terms of preventing adjacent segment degeneration? What are your thoughts?
I mean, we don't really do lumbar arthroplasties here, but yeah, cervical disc arthroplasty, I think there's a lot of good data for if it's in the right patient. So that younger patient that still has motion that you want to preserve, I think there's good data to show that minimizes adjacent segment degeneration. But I think the question is, a lot of this may just be the natural history of these diseases where they have degeneration in one segment. If we did nothing and followed some of these patients for 10 or 15 years, probably a lot of them are going to have additional levels that degenerate no matter what we do.
Yeah, I thought the mode of decay was interesting, that you developed a degenerative spondylolisthesis there with translational disc collapse.
Yeah. Well, if you look back at that initial MRI, she had fairly significant facet effusions already on that scan from 2009. So it may just be, and they looked worse at L4-5, I remember. So,
yes.
So it may just be a progression of that over a 10-year period. It looks like, L3-4 doesn't look great either. So that may be the next one to fall.
Yeah.
So we proceeded to the approach that you had discussed, Dr. Elder, with respect to Again, midline sparing decompressive laminotomies, partial fasciectomies, and then 3-column osteotomy, which we do intradiscal osteotomy here at our institution at L4-5. She was stable at that 5-1 level, so we did not include that in our fusion construct. Again, we were careful to preserve the facets in the tissue lowerly, just so that we can maintain stability there. Again, we use bilateral expandable cages as well. And part of the discussion with respect to the regeneration of bone and cartilage, we did local and allograft bone graft to increase our fusion. And then this is her follow-up films 4 years after. She remained stable and doing quite well in the clinic as well. So again, the discussions of total disc arthroplasty as well as the development of adjacent segment, again, our colleagues from TBI continue to follow their series, and the percentage is about 2 to 3%, which is still lower than fusion in patients that develop adjacent segment after single level total disc. So
we can see all what's happening at 3-4, and you predicted it. There's a gas disc now.
Yep.
So are there any stem cells we can offer? Is there some PR?
Yeah, unfortunately, I don't think there's great data to show that any of that stuff is beneficial, although I know that there are a lot of regenerative medicine centers that seem to promote that, but there is very limited data for that right now. Hopefully, maybe in the future there will be.
Thanks.
So we're waiting and seeing, and again, the saga's not closed, and maybe she'll end up with a disc replacement above now because it's not slipped at this point in time.
Correct. Okay.
Thank you, Cliff.
Thanks.
Good job.
Thanks.
Yeah, go for it.
Can I ask both of your opinions on the role, if any, of discography when you're considering a lumbar disc arthroplasty, and then whether you need a reference level? I mean, I know, the idea of sticking a needle in a healthy disc adjacent when you're trying to prevent adjacent segment disease is it doesn't feel great to me, but also it would be nice to have some sort of confirmation of discogenic pain.
Dr. Elder, so discography in a healthy disc, does it or does it not damage the nucleus based on what you know about chondrocytes? Is the needle caliber something that can ameliorate the damage? Tell us your thoughts about, first of all, a healthy disc injection with a diagnostic kind of a medium.
Right. Well, that's why I think Carrigy was the one who looked at who studied this long term and did find that there was an increased risk of disc degeneration with patients that underwent discography. Now, the annular puncture model is the standard one that we use to study disc degeneration in animals, where you just are poking into the nucleus and it'll degenerate. Now, we tend to use a larger caliber needle in relation to the size of the animal than you would use clinically for discography. So I think equating the two is not quite the same, but it most likely does contribute to some degeneration.
And is discography then in itself a still utilized modality? Is that something you would order in your clinic?
No, I haven't used that. And I saw that a couple of times in training, but that was many years ago. So I have not used that clinically in my practice.
Yeah, I've always been fascinated by it because it was literally like searching for a pain generator. And we now know, obviously, that pain has multifactorial assets, but there's an undeniable subgroup of patients where if you inject that contrast medium, they get a literal reproduction of their pain. And there's some very impressive images that show kind of a leakage going right towards a nerve that seems to replicate some of the pain. But again, this is a very kind of a dubious thing, and there's so many false positives and false negatives around, and it probably, if at all, overdiagnosis. And there's an undeniable lack of objectivity because nobody that I know of would inject a healthy disc anymore in good faith, even with a small caliber needle. Is it something that you saw in your training in Georgia? So they still did discography.
I've seen people doing it, at different points in my training, and I wonder, I guess the sequitur to my question is there a need for a reference level if you're already at the point of you've worked this patient up, they failed, and you're considering a disc arthroplasty very seriously? If you were to do a discography without a reference level and a healthy disc, and there was not pain, would that dissuade you from the disc arthroplasty? And is it even worth doing that? But it sounds like the sensitivity and specificity is so low that they may not be useful, is what I'm picking up.
Let's move on. Dr. Brian Anderson, what do you have?
Yeah, good morning. I have a patient, 66-year-old female. She's got 2 months of progressive neck pain and now bilateral hand numbness that comes and goes. And she's also having some difficulty on her feet. She's having to use a cane these days because she's has some balance. No prior surgery, no prior trauma, intact bowel and bladder. On exam, though, she's got weakness throughout her entire right upper extremity. She's 4 out of 5. She has this, what we diagnose as C6 radiculopathy dermatomally. She has a positive Hoffman's, an IBR, and a Lermet sign. Her BMI is quite elevated at 47. She's got a history of multiple lumbar surgeries in the past, hypertension, GERD, sleep apnea. She does live with her husband, and she is a retired nurse and PA. These are her x-rays that were obtained in the clinic. You can obviously see she's got degeneration at the 3, 4, and 5, 6 levels with a little bit of a spondy, mildly at those levels. Nothing terrible in the facets. We get an MRI scan. This is a T1, T2 stir weighted sagittals along with an axial. You can see there's obviously significant stenosis right up at the
So a couple of thoughts. So first of all, skip levels of disc degeneration. We all can kind of make some sense out of a continuous, let's say, subaxial disease. How can we kind of rationalize that there are skip levels of degeneration? What happens there that happens on some levels but not others? Any suggestions pathophysiologically?
Well, I think that depends on what the loading is, and the alignment probably plays a big role of that as well, and which levels start to degenerate first and which ones are carrying more of the load.
And what do you think is going on at the C1-2 level?
No history of rheumatoid or anything like that. So
no,
okay.
yeah.
Has normal joint, pretty large person. I think she's of a Pacific Island extraction. Very nice person, educated person. I think she was a physician assistant. And again, now has crippling neck pain and is losing function.
Yeah. So I mean, there's clearly cord compression from that ventral cyst. It looked like, I think you put up the CT briefly, but it looked like that was a softer cyst with a fair amount of bony erosion. Although actually, it looks like there's a calcified rim to it, and so clearly needs C1-2 stabilization. And so you always have to look out laterally, see how much of the C1 lateral mass is left, because it looks like on the right side it may be a bit eroded. The pathology is usually C1-2 instability on these, and so it's nice if you can limit it to a C1-2 fusion, and then that cyst will usually eventually disappear over about 6 months. And then the question is, do you have time to wait on their myelopathy to let it disappear, or do you need to get a ventral decompression if in pretty severe progressive myelopathy, because you don't have time to wait for 6 months?
But you'd advocate for a fusion. Would you take the fusion down lower and let it more disease?
I'd probably leave it for now until, I mean, probably over time it's going to cause a problem, but I'd try and be minimal in this, because I think with that right C1 lateral mass, there's a chance you're going up to the occiput on this one. And if you can't get great fixation in it, and that's going to be pretty limiting for someone who's not too elderly in this case.
Yeah, so she didn't have any instability on flexion extension, and she certainly did have this cystic structure ventral to the cord at the C1-2 level, and you can see the calcification in the rimming. So as you stated, she does have myelopathy at this point, and it's been getting progressively worse fairly quickly for her. So like you said, we took her to the operating room, and we did do a C1-2 fixation fusion. We started with a laminectomy at C1-2, and then from the right side, we took down the nerve, and then we were able to, from a lateral approach, really take away some of that mass. We actually sent a frozen sample, and it came back as pseudo-gout from the pathologist. And so we didn't attempt to do anything more radical with her. Otherwise, she did quite well during the surgery. We fused the facet joints, and here is a post-op CT scan. She had her surgery quite recently, so we don't have any any follow-up on her just yet.
So this metabolic disease is pseudogout calcium pyrophosphate disease. How does this kind of play into our disc physiology or motion segment physiology? So much of our motion segments is reliant on a healthy a healthy cartilage physiology, which entails a complex environment, synovial fluid, for instance, for joints. What's happening in these retention diseases, and why can they go out of control in one articulation like this?
Well, yeah, I mean, I think it's unclear why they seem to affect certain joints more than others, and especially C1-2. We seem to see that more often with pseudogout, at least in spine pathology. But it's challenging because a lot of the cartilage is avascular, and really it just gets all its nutrition from diffusion from the either within the disc or the synovial fluid. Or some vascularity from the surrounding bone. And so that's why once it's damaged, there really aren't great avenues to regenerate it at this point without replacing it.
So far she's done quite well, and actually her myelopathy symptoms have receded dramatically. It was not as technically difficult as I thought it would be to remove the majority of that mass. I'm not claiming radicality, but after we ligated that C2 root, we actually had a very nice posterolateral access to the ventral surface, and we distracted the joint and were able to extirpate most of that, not needing radicality. We put on that one collapse side, you're quite perceptive that lateral mass on that one side was very eroded. So we built that up with a structural allograft. So thank you. Any other insights for yourself?
No, this is a great learning case for me. I haven't seen CPPD in the spine as of yet, and it was pretty interesting. Once you see the MRI, you see the cystic structure, you understand that there's probably some extra motion going on here, even in somebody that didn't have that diagnosis. But then when you see the CT scan, it makes a lot more sense. Yeah, thank you.
Thank you, Brian. Great case. Now we'll switch gears from joints and discs to bone. Dr. Neil Patel, Penn State almost graduate and folded fellow here, has selected a case that shows a different type of pathophysiology.
Awesome. Thank you for that introduction. And here we go. All right. Okay. So I have a 74-year-old lady who presented to us on call with who lives alone with low back pain. She has schizoaffective disorder, dementia, chronic heart failure, hypertension, et cetera, et cetera. She had a ground level fall, and this was a first-time fall, no loss of consciousness, and had pain in the kind of low back region. On palpation and exam, found it to be localized around that L2 region, and CT scans up, and I'll kind of go through that. She was intact on exam otherwise, no other significant kind of labs. BMI was 36, and let me go through MRI first. So this is her MRI. She has T2 sequence, stir, and then axials that see compression of L2 with stir signal in L2, retropulsion, non-significant, but just enough to cause stenosis, loss of CSF around the nerve roots at L2 region, but intact on exam, no hyperreflexia, no clonus. This is her CT scan. Again. So
this is a nightly, literally several times a day consult for us nowadays. Osteopenic insufficiency fractures in the elderly.
Mm-hmm.
And again, the unique telltale thing here is the gas formation in the vertebra. So just in a bigger picture, is in your area in Rochester a model program underway to kind of stem this tide of osteopenia, which is seemingly rampant and just not being addressed at all? Is there a meaningful population health intervention?
So there hasn't been community-wide. Within the practice, there has been. We have a fantastic group of bone health endocrinologists that really help us in treating the patients who have osteopenia or osteoporosis and hopefully preventing future fractures and then helping us with medications in preparation for surgery. Nationally, I'm part of the National Spine Health Foundation that Paul Anderson and John Dymar have helped lead to really promote more awareness of bone health, because it's really at the primary care level is where we need to capture this.
Just on a quick side note along that line, are we at a state where measuring bone health on CTs will supersede the cumbersome and frequently false negative DEXA scans?
Well, so that's my hope. A lot of our research has been looking at use of Hounsfield units in predicting mechanical problems, and then looking at the effects of some of the anabolic medications on bone health, specifically in the spine. Because DEXA is a very poor measurement tool. The problem is it's still viewed as the gold standard for everything. But we have so many patients that have osteopenic T-scores, but Hounsfield units in the 40s or 50s, which is severely osteoporotic and are uninstrumentable. There is a tool called CT Bone Strength, where it's finite element analysis that's done, and that one is FDA approved as an official bone health measurement. So we've been using that increasingly to help get insurance approval for anabolic medications or diagnose osteoporosis. And I know Paul Anderson in Wisconsin spent a lot of time advocating and got a lot of the insurance companies to accept Hounsfield units. But really, you have to look at all the different modalities you have. So in a patient like this patient has likely what you would call a fragility fracture at L4 as well, where there's end plate irregularity and probably up to 20% of height loss. And so we look on all the x-rays, all the CT scans to see, is there a place where they have a fragility fracture, because that by definition gets you to a diagnosis of osteoporosis and will qualify for treatment.
So we don't want to put you on the spot, but the unique thing about this fracture is that she has gas in her vertebra. Right. So you want to take this a little bit further, Neil?
Yeah, so gas in the vertebra.
But you know that one's going to collapse.
Yeah. So the gas in vertebra is now, or at least, from learning now, it's Camel's disease. It presents as a delayed post-traumatic vertebral body collapse, which she did. So she had fall about a week ago and then presented later. For the in literature, it occurs months later, but it does occur later than at the time of incident. And again, it's complicated by vascular necrosis, which gives the air or has that kind of air signal in the CT scan. And again, so this is different than the vacuum disc. And treatment for that then becomes a little bit different as well from what we learned. So for her,
So let me just stop you there. So what do you think about Camel's disease? What do we know? Is this a separate entity, and why does a vertebral body that's probably more fatty marrow than real marrow do this? Is this a mechanical phenomenon? Is this an actual avascular necrosis, as the Camel's disease entity ascribes it to?
Yeah, I mean, that would be my guess, is it's more the avascular necrosis, and it doesn't look like there's much extension from the disc, because you tend to have more of a cortical margin along that end plane and more sclerosis. So it seems to be something within the vertebral body more so.
Yeah, Paul Anderson was my faculty mentor, always theorized that this was actually a fat necrosis, an outflow problem, where there's literally a congealment of venous stasis within a fatty marrow that then leads to the actual necrosis of the osteons. But obviously there's a much depleted osteon skeleton basis. The osteoid inside these vertebral bodies is heavily compromised. So this is a case that we treated with predictably?
Yeah, so, initially looking at the case, looking at the bone health, retropulsion, but in an intact patient who has other comorbidities, mental illness, heart failure, etc. I thought it was going to be a little bit more complicated, but as Dr. Chapman kind of pointed out, we were able to diagnose this Camel's disease and then kind of go for the most simplest treatment we could. So we were able to just do a kyphoplasty with our IR colleagues. So this is intraop images from that. So they did a unipedicular approach with the first x-rays, kind of like the Scotty dog with going right down the pedicle. Then you have the cannula in the pedicle, balloon, and then cement. So we're able to place cement, we're able to restore height. You could see the retropulsion is a little bit lesser compared to the CT scan. I don't have an x-ray to compare. We got a lot of cement in, and patient's pain significantly improved. She did develop AFib, so she's just getting retrovert for that and doing that. But clinically, from spine perspective, she's improved. She's able to walk again and et cetera. So this became it's very informative for me in terms of understanding this disease and treating it appropriately, minimal invasive kind of.
Yeah, for me, the Camel's disease, or AVN, is one of the most overlooked sub-entities in these insufficiency fractures, fragility fractures, and one of the most gratifying to actually treat with cementing in terms of height restoration and just avoiding bigger surgeries. Any thoughts on yours? Is this something that our radiology community has overlooked in terms of calling it out more aggressively?
Yeah, I mean, that's the thing. I think the CTs are very helpful for this and degenerative disease, where looking for these vacuum signs, whether it's within the vertebral body or the disc space, you know that there's going to be significant collapse when they're weight bearing. And so I think it's very easy to just look at this supine imaging and say, oh, everything's going to be fine. And it's relatively well aligned, but the instant they stand up, that area is going to collapse. So I think using cement to open that space up is a great treatment for these. And then the other critical thing to treat is to get them to endocrinology or whoever manages bone health and get this patient started on medication, or she'll be back with additional fractures.
Yeah, no doubt. Should our radiologists do more opportunistic ROI measurements? Should we ask them to do that more routinely?
So we typically just do our own, and because I try and measure it close to where we're placing our instrumentation. I look at it particularly at the UIV on my deformity constructs, and sometimes use that to guide where I'm going to stop. But also as more of a screening tool to say, okay, this is someone I really need to get to the diagnosis of osteoporosis so we can get them to qualify for medications. I think we've worked with some of our radiology group here to try and do some automated measurements too, where it can flag patients that will be at higher risk. And then I think the new photon counting CTs have even more impressive capabilities that are upcoming. The challenge with Hounsfield units is really looking at the cancellous portion. So the pedicle has a lot more cortical bone, which is about 60 to 66% of your fixation comes from there. And so, some of the medications have different effects on cancellous versus cortical bone. And so I think we need more measurement of changes in the cortical portion of the bone as well, which hopefully photon counting CTs will give us.
Do you think at some point we'll be able to kind of simplify the imaging? Because at this point, we need a CT scan, we need an MRI and X-rays, and the advent of black bone MRI, et cetera. Do you think at some point we'll be able to have one image that tells us all the information we need for surgery?
Maybe at some point. The problem is, I know people have been looking at VBQ scans more to measure bone health on MRI, and we found that to be far more inaccurate, and that the Hounsfield units still are a much better predictor. And then even with photon counting CTs, they're not great at the soft tissue. So I think it's still going to be, to look at the neurologic elements compared to the bone, we're still going to need at least two modalities. And then they're both non-weight bearing, so you still are going to need the weight bearing images as well.
Yeah.
All right, no go on the MRI, sorry. Good one, next question. Thank you, Neil.
Yeah.
Okay, so next we have Dave Davis, and we're going to go back to metal treatment for degenerative disc problems. And I think we're going to the neck, right, Dave?
Yes, sir.
So we're going to the C-spine now. So Dave Davis, you commented on some of the cases earlier.
All right, so this patient is a 60-year-old male.
who presents with a loss of dexterity in his right hand, as well as pain radiating to his right upper extremity and between his shoulder blades. He has headaches, and these are his initial flexion extension films. On physical exam, we note that he had weakness in finger abduction and had a generalized lack of dexterity in the right hand, as he described himself, and he did have a positive Hoffman sign. MRI, as below, shows multiple levels of pathology. And then on the axial views as well. So we can.
So, yeah, if you go back to that MRI, so 4, 5, 5, 6, 6, 7, I don't know how many patients, I usually say about 30 patients in the clinic. I'll have numerous patients with this pattern. I mean, this is just a very repetitive thing that 5, 6, 6, 7 are two action discs kind of somewhat collapse, and then 4 or 5 slides on top of that and develops instability to some degree, and there's some degree of neural entrapment. So I don't see a mild myelopathy, maybe a neuric 1 or 2, and more radiculopathy and a relatively tight canal between 4 and 7. Any thoughts on, of course, we've treated him non-surgically, but any thoughts on how to kind of jump beyond 3-level fusions?
Right. And so, can you go back to the x-rays?
Yes.
Dave put this together. Oh, yeah, thank you. Great.
1, 2, 3. So he has a fair amount of disc collapse at 4, 5, 5, 6, and 6, 7. There's not really any translation. It looks like there's a component of some congenital stenosis as well, causing the central stenosis, especially at 4, 5, and 5, 6. And so my favorite, probably in this case, I would probably focus on 4 to 6. And even though 6, 7 does not look perfect, but I would probably offer ACDFs from 4 to 6. There's a lot of more height loss than I would like for doing some sort of arthroplasty. The alignment's decent, so laminoplasty could be another consideration as well at those levels, but I worry about that a little bit with given all the radicular symptoms.
Yeah, those are very perceptive insights, yeah. So we put patients with this kind of a very ubiquitous thing through a non-operative program with traction, shoulder girdle strengthening. Again, we try to direct PT away from doing range of motion exercises and stuff like that, which seem to irritate them more. We do use selective nerve root blocks. And again, we try to re-educate patients about this and try to minimize opiates, which in our area seems to be very difficult sometimes. But so this is a pretty active guy, right? And
yes, he's really active, educated, and really plagued by the radiculopathy symptoms. But the note of myelopathy as well on his physical exam, leads us down a more aggressive pathway.
In your residency in Georgia, how did you treat this? Was this a fusion case pretty automatically, or?
Yeah, I mean, mostly what I saw a lot of posterior cervicals. So I think laminoplasty is a reasonable option, but as you stated, the radicular symptoms bring into question, how much we address that. But that's probably what we would have done in my training.
So I love laminoplasties. I think it's one of the most overlooked and underutilized surgeries, at least in North America. You said that you would not want to do a laminoplasty in patients with radicular symptoms. Can you expand on that a little bit more?
Oh, yeah. So I think it's reasonable. I just find I really try and preserve that. So if they have bilateral, I think it's harder to get a good foraminal decompression, and then you end up violating the facet joint a little bit. So I worry about the stability long term. But I think you certainly can address radiculopathy. In this case, there's a lot of the compression is anteriorly, and so I think addressing it through an anterior approach gives you a better decompression long term.
Yeah, I struggle with that decision-making sometimes also in patients. Again, if in doubt, prefer a laminoplasty over multi-level fusion. But again, when I have patients with substantial neck pain, which he did have, I start halting and pausing about thinking in terms of laminoplasties, and that's very subjective. I don't have an objective criterion for that necessarily, but this patient did seem to have more neck pain, as I remember that, than what I was happy for. And again, if in doubt, I would want to do a laminoplasty as long as the patient gets an active straight or ideally an extended neck, which he still had. So I just wanted to hear your thoughts in terms of laminoplasties. So let's see what we did. We did not want to do a 3-level fusion. So this is what we did. What do you think about this kind of a concept to try to create a hybrid between mobile neck and rigidity, and being clear that our FDA does not like us to do 3-level disc replacements?
Yeah. Yeah, I mean, that's a challenge, and the hybrid constructs are technically off-label as well. But I think it makes sense in some of these situations. So like for me, I always worry with maintaining motions at the segments where it's still going to be, even if you remove that ventral disc centrally, it's still going to be a bit tight at 4-5. And so longer term, they can still go, when you maintain motion there, you can still go on to develop myelopathy. Whereas the fusion, as long as it fuses, then you should be protected at that level. But I think doing a hybrid, so maybe even doing like a 4-6 ACDF and then a 6-7 arthroplasty, if you need to treat that level as well, would be a reasonable option too.
So, yeah, this is a lengthy discussion with this gentleman. And again, technically, I think we had a nice thing. He does not use nicotine. Do you have a longer-term follow-up film?
I do. So this is his first follow-up. Very happy with his result. And then this is his most recent.
So he's actually done something interesting. He's cracked or broken his screws at the fusion level in between, which I thought was very interesting. And again, the disc, actually that disc space, the graft settled in there. He's not a smoker. I thought that was mechanically very surprising. We obviously did not immobilize this patient. We let him move. The disc arthroplasties are doing their job. I don't think we over-distracted him badly. Any thoughts on, I mean, I used this plate, I don't want to brag here, but in the thousands, and why this would break both screws. These are 4.0 screws at this 1.5/6 level kind of surprised me a little bit.
Yeah, I mean, that's the challenge, is even when everything goes well and it's the best case scenario, is we're still going to have a decent number of failures. And I'm not sure there's anything different to do on some of these. I wonder, I still mostly use structural allograft for mine, but I have had some of these where there's graft resorption, and so wonder about using some of the new 3D printed titaniums where you get a little bit better ingrowth at the end plate.
Yeah, I'm probably a little bit too cost conscientious. I've, again, loved structural allografts, and I found them to be extremely powerful, especially with posterior fixation, which we're not talking about here. But this case kind of gave me pause, because it literally tells me that the cervical spine would like to move and would like to move at 5-6, and is upset that I would have somehow violated this harmonious motion cascade with a single level fusion. So that was just interesting for me to see. The patient's actually, how's he doing?
Patient's doing well. His last report, he had pretty significant decreases in both his axial neck pain, and then his radicular symptoms are largely improved as well.
So I'm still not sure about these hybrid constructs, I have to say. I personally have preferred doing a 3-level disc arthroplasty on him rather than doing something artificial, which is still off-label, I realize, but more palatable. So I don't know. You mentioned hybrids also. Is that something that you actually do in your clinical practice, or is that too difficult to get past the insurers?
Yeah, insurance is a difficulty. And then, unfortunately, I don't get too many. My practice is pretty heavily weighted towards deformity and a lot of revision, so I don't get too. It's less common that I'll get a nice 1-level or even 2 or 3-level patient with radiculopathy or more straightforward myelopathy.
Good. So what are you going to do in your practice come summer?
I mean, I really like the idea of hybrid constructs. Until 3-level arthroplasty is an option. I I think more than that would give me a little bit of pause. But one of the points that I thought was interesting listening to you guys discuss is when I was in training, the hybrid constructs that I investigated, we would typically fuse at the caudal-most level, and then arthroplasty above. You mentioned fusing cephalad and then the arthroplasty below, and obviously there's no consensus because it's still off-label and we're still new and experimenting and understanding this. But just curious of your rationales for those things.
That's a great point, Dr. Elder. So adjacent segment disease in the cervical spine, the famous Hillebrand studies, is that more a rostral problem or a caudal problem? Where should we invest our chips if we have a hybrid construct? Should we try to ameliorate the rostral disease progression or the caudal one?
Well, I think it's more challenging than we've originally thought, because I think a lot of it is probably has to do with alignment too, and the pattern of the spine. As we've started to understand with some of the Russelli classifications, I think we'll have much different failure mechanisms. So I think it's hard to put everything in one box. I look at it as well as what's the disc collapse, which one is a fairly healthy looking disc that's more a radiculopathy without much central stenosis or congenital stenosis, and that would be the one that would be more amenable to motion preservation for me.
Great point. Yeah, no, so I don't have a final answer on that either. As you know here, I tried to hedge my bets rostrally and caudally, but it is more complicated, as Dr. Elder said. And in retrospect, I would probably still do the same thing, even though I'm now seeing that this is cracked. And so we're going to watch 5-6 by measurements of the spinous process. He did not have the critical motion. So, but we'll have to probably get a CT down the line to see what the allograft has actually done. He's like a half year out now, so spine is never a never-ending conundrum.
Yeah.
Thank you, Davis. Thank you to our fellows. I want to recognize Dr. Davis did this presentation last night after we were in the OR for a long time. It's a true pleasure to have Dr. Benjamin Elder, an MD, PhD, professor of neurosurgery and orthopedics and biomedical engineering, a true Renaissance man who is involved not just in cartilage and bone engineering and an active neurosurgeon with a rich practice. A very distinguished background. He had his bachelor's and master's degrees in molecular biophysics and biochemistry at Yale, and his PhD in bioengineering from Rice, his MD at Baylor College of Medicine, and then his combined MD-PhD program was concluded there. He did his neurosurgery residency at Johns Hopkins and did a complex fellowship and an additional fellowship in orthopedic deformity surgery under the famous Dr. Khaled Kabesh, which is fantastic to see. So this kind of a crossover pollination is amazing. He is, again, the Associate Program Director for the Neurosurgery Residency Program, and he does a lot of spinal deformity and complex spine surgery, and I'm so glad to see that a neurosurgical colleague is also involved in bone health, which is so important to kind of spread the message around and become more active in this. And Dr. Benjamin Elder is so kind to talk about cartilage and bone regeneration and what's happening next, so we don't have to put titanium, stainless steel, and all sorts of other polyethylene contraptions and methyl methacrylate assemblies into patients. So thanks for joining us today from Rochester, Minnesota.
Perfect. Thank you for having me. Do you want me to share my screen? Is it?
Yes.
Okay. Perfect. All right. These are my disclosures. None of them are relevant to the talk. So spinal fusion is still a very common procedure. Over 250,000 and probably much higher, since this is older data, are performed annually. Posterolateral lumbar fusion, it probably has the highest rate of pseudoarthrosis, and we just reviewed some pseudoarthrosis cases, but some studies have shown up to 50%, especially in more challenging patient populations. In revisions, it probably have some of the highest rates and highest morbidities. There's many factors that are involved in a successful fusion, but proper function of the bone graft is really the critical factor, in addition to adequate stabilization. Spinal fusion biology is still not perfectly understood. It's dependent on a complex process with the graft material, local biology, biomechanics, as well as systemic and external factors. We do have some data from animal models. The classic Bowden rabbit posterolateral fusion with iliac crest autograft is one of the more commonly used ones. Non-primate models do have an easier initiation of osteoinduction, though, and it's pretty rare that primate models are used for fusion studies due to cost and difficulty. There's also different biomechanics with quadrupeds compared to bipeds. The animal models that we use definitely are not perfect. There's 3 temporal phases of spinal fusion with an early inflammatory phase, then reparative and remodeling phases. So currently there's a plethora of different bone graft options. Some of the most common are autograft, which can come in different formulations and be both vascularized and non-vascularized. But this can be limited due to a lot of factors with the patient and difficulty obtaining the graft. Allografts are very commonly used, as we just saw on the last case, and come in different formulations with fresh frozen, and freeze-dried. And then we have various DBMs, which is really an allograft, but the goal is to preserve a lot of the growth factors and BMPs within it. And those can be highly variable because they're each, as with allografts, because they're each created from different patients. And so depending on if it was a young patient or an old patient or a lot of the different factors of their bone health, you can get vastly different growth factors as well as bone within there. And then there's a fair amount of cell-based grafts that have been increasingly used, where they have proprietary processes where they separate the cells from the bone graft and then recombine them. And so they're regulated just as a human cell and tissue, which is an easier pathway at the FDA than an actual biologic or a device. And then there's different bone graft osteoconductive matrices with ceramics like calcium phosphate and calcium sulfate that are used in a lot of injectable formulations, collagen, composite grafts, as well as some of the bioactive glass and synthetic polymers. And then, of course, we have a plethora of different growth factors that are used. BMPs are really the only ones that are used specifically in the clinic with the infused product. But a lot of the DBMs are intended to maintain a lot of these other growth factors, or platelet-rich plasma is another avenue that has utilized growth factors. The problem is it's hard to control the release of any of these, and you don't know what concentration you're getting. So looking at different studies and having uniform outcomes is very difficult to figure out. So autograft has really been the gold standard for many years, especially using corticocancellous graft from the iliac crest. It's the only material that satisfies all the requirements of a bone graft with osteogenesis of differentiated and undifferentiated cells, osteoinduction, which is really the growth factors and bone matrix proteins that allow for that, and then osteoconduction, and serving as a scaffold for bone to grow with the hydroxyapatite and collagen. They're biocompatible and have no risk of disease transmission or immune rejection, which we can get with some of the allografts. They're typically harvested locally or from posterior iliac crest, anterior iliac crest, or ribs, and occasionally use vascularized fibulas for anterior reconstructions. But again, yeah, they do have significant limitations and complications at the harvest site as well. Autograft is fully mineralized, so its maximum osteoinduction may not be realized, but that's probably a lower concern for these. BMP2 has obviously been widely used, most often off-label for the past 20 years. It's highly osteoinductive in both animal models and humans and has high fusion rates. It has to be used in combination with Medtronic's proprietary absorbable sponge, and it does have complex release kinetics, which is what's made expanding its indication so difficult, because every time any little change is made, you have to do a lot of release kinetic testing in addition to having clinical data. There was an entire issue of the Spine Journal devoted to safety concerns of this 15 years ago, which have been widely looked at, and it really has not been used in anterior cervical procedures due to life-threatening neck swelling, as well as heterotopic bone formation and osteolysis, and some potential for carcinogenicity as well, though the data is more mixed on that. So the area we've been looking at is using bone tissue engineering and polymer synthesis to develop new materials that we can use to really optimize fusion. And so we've looked at materials like polypropylene fumarate or PPF, PLLA, and multiple other polymers have been used in other groups as well. And so we'll talk about some of those in more detail. And so tissue regeneration or regenerative medicine really incorporates a lot of different areas with new technologies that we now have 3D printing to make scaffolds, stents, and other implants. bioprinting, and then incorporating nanoparticles and other nanotechnology into our grafts, incorporating that into the practice of health and looking at different regenerative medicine approaches. And we've looked at bone repair, nerve regeneration, as well as spinal fusion, and actually cartilage regeneration and repair as well. And some of this is affected by aging, where we get increased antioxidants and osteoporosis. Obesity has caused a big problem for bone healing. The environment with hyperglycemia and diabetes that we get causes systemic issues, but also causes local problems with osteoblast function. And so we've looked at incorporating a local control of or local glycemic control into some of our grafts as well. And then other diseases like psoriasis, autoimmune diseases can also cause problems. And then there's also ways to use tissue regeneration for targeting cancer cells, as well as delayed drug delivery. And so there's a lot of different industries with bioengineering, sensors, environment, and food and pharmacy that are also incorporated into this. So we mentioned fumarate earlier. So fumaric acid is an intermediate product in the TCA cycle that we all learned about many years ago. That helps as a source of intracellular energy with ATP. That's non-toxic as well as naturally existing in the human body. And so molecules like this are usually good avenues to incorporate into tissue engineering constructs. And so we have a lot of ways that we can have bone diseases and injuries, as we just reviewed many of the cases, showing great examples of these. So with trauma and different fractures, osteoporosis has become a huge epidemic with 200 million people suffering from this. And a third of women and a fifth of men will experience osteoporotic fractures in their lifetime, often that are undiagnosed. And then oncology, as people live longer, very high rates of cancer in the population, and 1.8 million new cancer cases in the US each year with metastatic disease. And so, as we just saw in one of the earlier cases, PMMA, or polymethyl methacrylate, is the common bone cement that we use in a lot of orthopedic procedures for kyphoplasty and vertebroplasty. As I'm sure many of you have noticed, it's mixed on the back table. If you ever held the container as they're mixing it, it's a highly exothermic reaction, so it gets very hot during this mixing. And then it incorporates a lot of toxic chemicals, as you all notice a pretty clear smell when it's getting mixed. And so this is the main cement that's used. So it's PMMA plus BPO, and then that's combined with MMA and DMT. And so the disadvantages are that it's exothermic, so everything has to be done outside of the body. It's also a lot of these initiators are highly toxic, and it's non-degradable. And then the mechanics of PMMA are extremely rigid. So it's probably much closer to some of the metal implants that we use than particularly osteoporotic bone. So if we're looking at designing an ideal cement, it would be non-exothermic, so there's no heating, non-toxic products, and then also biodegradable. So PMMA will stay there almost forever in its same form. And so it would be great if we had materials that you inject with structural stability initially, but eventually the body would regrow bone as the material degrades. And then also you want them about the same mechanics or softer than bone, so it provides some structural support. But again, most of these are treating osteoporotic bone. And so you want more limited mechanical properties, or the ability to vary the mechanical properties for the situation. And so there's a lot of different synthetic and natural polymers that are biodegradable that can be used. So polycaprolactone is one that we've used for PCL, and then PLA, PGA have been commonly used, as well as PLGA and polyethylene glycol, or PEG. And some of these are used in things like suture material. They've also been looked at biodegradable cages in the past, and there were some problems with how quickly those dissolved and providing enough structural support in the interim, as well as some cause inflammation with some of their byproducts. And there's natural polymers like gelatin, collagen, chitosan, alginate, and hyaluronic acid that can also be commonly used. So a couple of years ago, in 2022, the Nobel Prize in Chemistry went to this group of individuals, and this was for developing click chemistry. And this is a chemical reaction in which molecular building blocks snap together quickly and efficiently using the combination of an azide and an alkyne molecule. So it develops this click reaction, as you can see in the bottom here, where the azide forms into a ring structure as it comes together. And so this allows for combining different polymers together more easily. And this can be done in physiologic conditions. It's also non-exothermic because there's really no energy release because this reaction occurs so readily. And as with most polymer synthesis, you usually need an initiator or a catalyst. In this case, it's non-toxic because it does not require these. As unfortunately, like in PMMA, the initiators and catalysts are often highly toxic chemicals or things like UV light that also have significant toxicity or significant heat. And so we've been using fumarate click chemistry to develop new bone cement. So again, the advantages are that it's non-exothermic, non-toxic, biodegradable, and then still softer than bone, but with some structural integrity. And so in this, we have polypropylene fumarate, and then it's combined with BCN in the click chemistry reaction. And so this was one of the studies we looked at in developing the click chemistry cement for minimally invasive bone repair. And so this is our POSS-based nanohybrid concept, or what we call the click-on cement. And so we have our azide group with that N3 attached to the POSS, and then it combines through that azide addition to make the nanohybrid cement. This tends to harden over about 20 minutes, and so you do have a nice injectable formulation that can be used. And so when you're looking at biocompatibility, you want to see how well do cells proliferate on it, and does it allow for stem cell osteogenesis, intracellular adhesion, as well as in vivo bone regeneration. And so in that study, we looked at the rat critical size calvarial defect, and then also looked at rat posterolateral spine fusion and vertebral body defects. And so this was some of the initial data showing stem cell growth on these. And then OPN and OCN are some of the bone markers that we use, as well as alkaline phosphatase activities. That's osteopontin and then osteocalcitonin. And so we see that our click-on cement at that 3:2 ratio seemed to give us the most robust response. So we have excellent expression of alkaline phosphatase as well as osteocalcitonin. And then again, see a nice healthy growth of stem cells on this, as well as differentiation of the stem cells. And so this is images of the rat calvarial defect. And so this is the click cement at that 3:2 ratio, where we see that defect is almost completely filled in compared to some of the untreated controls where there's really no bone growth. And then this is the bone volume to total volume. And again, we see that the 3:2 ratio of the cement seemed to work the best. Looking at the other tissues, there were really no effects systemically. So again, no toxic effects. And then these images show some of the new bone growth we're seeing on histology. So the NB is new bone, and then this is the polymer as it's degenerating. So we see some excellent new bone growth, and then compared to the untreated control, where we don't really see any bone growth developing in there. And then this was looking at the posterolateral fusion model, in which it was applied either bilaterally or sometimes unilateral with an empty control just from decortication. And so we see substantial bone growth along the transverse processes. And then this was looking at it, injecting it into bone void within the vertebral body. And there's a lot of overgrowth around it, but we do see nice bone growth within there as well. And then, so one of the issues we talked about was temperature control. So you can see with PMMA, it's a highly exothermic reaction getting up to almost 90 degrees Celsius, as opposed to the click-on cement, which is very stable at physiologic conditions. These are live dead assays showing that we do have more dead cells in the PMMA group and mostly live cells in the cement group. And then this looks at degradation characteristics. And so the cement is fairly robust mechanically, and does so even to reach about 50% of it takes about 10 months, so close to the order of what fusion would require, compared to PMMA, which even out to 24 months is still almost 100% intact by weight. And so this was again, looking at the bone cement, and the bone obviously has a porous structure. And so this is trying to recapitulate some of the porosity. So in this one, we included porogens or salts of different size to change the size of pores that would form within the scaffold through a similar process. And so these are just scanning electron microscope images of the different pores, of the different porogens that we use, so small, medium, and large, and showing some of the structure that forms afterwards. So the salts are used during formation of the polymer, and then they're leached out and dissolved once the polymer is formed, leaving the pores behind. And so again, this shows a representative image of this. And then this is looking at the compressive strain as well as the compressive moduli of these groups with the small, medium, and large pores. And so in this one, we see that with the large pore size, they're actually left with the highest compressive modulus because it's harder to fit them within this area. So you actually have more bone left, where the small ones are probably too small, where there's not, it's probably closer to an osteoporotic type of porosity, where you have increased and more irregular porosity and thinner pore walls, so you have lower compressive modulus. And so these are some of the more detailed images, again, showing the live dead assay, where they all allowed for stem cell viability, but showing the cells, again, within these pores and the larger pore size that seemed to work well. And then also allowed for good collagen growth even at 2 weeks. And so this is looking at it again in that rat calvarial defect model. So at the empty control, we don't see any growth. But as we look at some of these porous cements, we do get some ingrowth. It doesn't look quite as good as what we saw in some of the last images with that 3:2 ratio. But there is reasonable bone surface area within here. And again, with this porous cement, it does show good viability in the bone volume to total volume. And then looking on the histology, we again see the more porous structure with the porous polymer within here, and then new bone growth around it. And then this is the original bone. So it does seem to incorporate fairly well within there. And then this is looking at taking it a step further and combining our moldable click chemistry, or making a more moldable formulation rather than injectable, so a little more viscosity to it. And then also encompassing growth factors within it, so both VEGF and BMP. And so in this one, we incorporated the nano hydroxyapatite within the scaffold, BMP2 microspheres, as well as VEGF microspheres with delayed release through there. And so this is a post-lateral fusion model, and then putting the cement in and watching for new bone formation and hopefully fusion. And so again, this shows with this moldable cement that you can make into multiple different formulations and mold into whatever shape. So it fits very well either into a facet joint or along the posterolateral recess for good approximation. The compressive stress is a little bit lower than what we saw on some of the last materials. And so this is looking at some of the release kinetics. And so we see this delayed release where it takes up to about 6 weeks during the inflammatory phase of bone healing to release most of the BMP. And then we also see delayed release of VEGF over the same time period. Figuring out these exact release kinetics is important for future bone regeneration studies, because you clearly need some vascularity of your graft to support the cells that are in it. Previously, we had looked at tagging stem cells in a mouse fusion model, and a lot of the stem cells that are implanted actually die out over those first 6 weeks because there really isn't vascularity, and then new cells will start ingrowing over that time. And that's been some of the challenge with using stem cell products, is that a lot of those cells disappear. Some of the cellularized allografts are the cells really doing much, or it's possible they're leaving growth factors behind that do support future ingrowth and bone regeneration. But I think that's certainly an area that we need more exploration of. So this was done in a slightly larger model with a rat posterolateral fusion model. And so we did a empty control. Our positive control was autographed from the iliac crest, as well as BMP on the collagen sponge. And then this one was our moldable click chemistry cement. And so we can see that this actually seems to have a more robust than what I would think is the gold standard of autograft and BMP. And so these are some of the eventual micro CT images. We put in similar volumes of autograft and BMP initially, and we see we actually get overgrowth beyond the transverse process on this one, as well as significant overgrowth using our click chemistry cement, even though it was just applied over 2 transverse processes as for a typical one-level fusion. The fusion rate was actually pretty similar based on manual palpation. And then when we look at the bone volume, as we see in those micro CT images, we had a substantially higher bone volume that grew over the 12 weeks of the study, even though the initial implantation volume was controlled for. But the CT-based fusion score ended up pretty similar with solid arthrodesis in all of the groups, which is typical in the rabbit studies, and then no fusions as expected in the negative control. This is looking at developing an injectable formulation, again, using the incorporation of nano-HA, BMP2 microspheres, and VEGF. And so this would have some potential future applications as replacing PMMA. So again, this is an injectable one that can be injected through a syringe, and you can change the process, or you can change the viscosity of this to allow for easier injection and allow for it to harden over a longer period of time. Again, we see a similar compressive stress to what we saw in the moldable group, but again, not quite as strong as these non-porous formulations. And then saw similar BMP2 release. This one was taken out to 25 days, and same with VEGF, where we had about 50% release by that around 4-week mark. And so what we attempted to do inner body fusion model using the rabbits, but this proved to be very challenging based on their nerve anatomy. So there were a lot of nerve injuries trying to access that disc space, and it was just too small of a window to work in. And so we ended up just doing the injectable within the posterolateral space on the rabbit model. But again, we used empty control, allograft and BMP2, as well as our injectable formulation. And similar to what we saw in the moldable group, we saw a substantial fusion with injectable cement. And so currently we're actually doing a large animal study where we can do an inner body fusion using sheep. And this is one of the standard models that does allow for using human pedicle screws, and they tend to be very short, about 20 or 25 millimeter screws. And so in this, we're doing inner body fusion using the control with structural allograft from the spinous process and BMP sponge. And then on the other side, doing inner body fusion with our injectable formulation, and then the moldable scaffold posterolaterally versus local autograft and BMP sponge. So we've done, I think, 3 of our animals at this point out of the 8 planned. So hopefully we'll have more results in the future. And then those will be taken out to 6 months. These are just some of the images. So we've spent a lot of time talking about bone regeneration for fusion, but what about non-fusion, which is really the goal for the future? So my PhD was focused on cartilage regeneration, actually more for the knee, but while I was finishing up my project before I went back to finish med school, we started looking at facet joint regeneration. And so facet arthropathy is obviously a significant disease affecting almost 60% of adults by 30 years and probably 100% by age 60. Major source of pain and disability, and relates to progressive instability and spondylolisthesis, as we saw in some of the cases earlier this morning. So this was the original study in our lab group looking at a self-assembling process in articular cartilage, tissue engineering, and then I had previously looked at using different growth factors, TGF-beta1, BMP2, and IGF-1, as well as hydrostatic pressure, and combining these to improve the mechanics of our cartilage. And we actually got it within the range of what human articular cartilage is, at least for the knee. The spine, the facet cartilage is a little bit different. And then we looked at actually characterizing what facet joint cartilage mechanics and biological or biochemical makeup is. And so the aggregate modulus was about 400 to 500 kilopascals compared to about 800 kilopascals for knee articular cartilage. And then the Young's modulus was actually fairly high at around 10 megapascals. Which is closer to the range, or slightly higher than our knee articular cartilage. This was another study we've done more recently since we're using a mini pig, Yucatan mini pig model to study our implants. So we wanted to see what the mechanics were of these. And so again, similar, they have a slightly different makeup with a more rounded joint and slightly more ovalized than we see in some other species. But similar depth. Again, the Young's modulus was in that 10 to 15 range, and some of these were actually a little bit higher than what we saw in the canine model. And the aggregate modulus was slightly lower, so mostly in that 2 to 300 range. And so one of the challenges with the articular constructs, articular cartilage constructs we made many years ago was how do we incorporate these into the surrounding bone? So if you're going to use these in knee arthroscopy, how do you get it to incorporate and grow into the surrounding bone? And so the lab group has come up with a way to actually grow these on top of a bone scaffold, so either on a ceramic or on native bone. And now as it's developing in the self-assembly and scaffoldless approach, it'll actually completely grow in and look much more like native cartilage, where there is a clear biologic interface between the bone and the cartilage. And so these are some of the representative constructs that can be made, and seeing how these can conform to whatever the surface morphology is, including these rounded surfaces. And so this was a preliminary study looking at the difference between canine, porcine, and primate. So again, we see slightly higher aggregate modulus in canines compared to porcine and primate. And then this is a human healthy joint surface compared to degenerated one, which we see in most of our operative patients with severe degeneration of that cartilage surface and some of the surrounding bone. These were some of the 3D images we took of Yucatan mini pigs to try and come up with the surface morphology and then create molds to create these implants. And so the envision is to have a minimally invasive approach where you access down to the facet joint, and at least for now, chop out a piece of the inferior articular process, much like we would do for an osteotomy, but then implant this osteochondral scaffold and then close the joint capsule back up and have the motion of the joint holding it together with the patient immobilized temporarily to hopefully have that bone surface incorporated into the joint. And so we've been trialing this in the mini pig model. So this was some of our cadaveric studies of the mini pigs trying to come up if there was a way to get something like a spike to hold it in place more versus just ridges. But a lot of these don't work very well because the bone is very heavily corticated. And so currently we've just been using a flatter implant that stays in place due to the friction and closure of the joint surface. And so this is actually an image from some of the earliest animals that we've done the implantation on. So this is where you can see the native surface of the superior articular process and where we've removed the inferior articular process. And this is the osteochondral implant that we've put in. So again, this shows the implant in place being held just by the friction of the joint closing down when we take away the distraction with the laminar spreader, and then closing the facet capsule with proline sutures to help it heal. And so we're still preliminary. We've done 2 animals so far and then had some mechanical issues in the last batch of implants. So hopefully there'll be more to come on this. But I think the goal will really be to have some sort of biologic replacement and avoid fusions in the future. But in addition, if we do need fusions, I think hopefully we'll be able to get up to some place where there is 100% fusion rate and we're not dealing with some of the challenges we are now. So I'd like to acknowledge my close collaborators on all these projects. So I work in a combined laboratory with Li-Chun Liu, who's a bioengineer, and then Zhifeng Liu is the polymer chemist who's really been instrumental in designing a lot of these click chemistry polymer synthesis, and our graduate student, and then some of our other postdocs. And then Mike Uzemski was a close mentor who was also co-running this laboratory before he retired a couple of years ago. And then Carrie Athanasio is my old PhD mentor, who's my close collaborator on the cartilage and Facet cartilage regeneration projects, who's now out at UC Irvine. And so we've been doing all the animal studies at Mayo and working collaboratively with their group. Thank you.
Outstanding. Dr. Randy Davis was also commenting on this. So I don't even know where to start. This is so much intellectual effort and work. It's just truly amazing. Let me start with the last thing first. So facet joint loads. So these are actually, just for the simple orthopedic surgeon speaking here, the facet joint loads are actually exceeding that of the knee joint. Is that what I heard, at least in the animal models?
No, so these aren't the loads faced by the joint. These are using creep indentation testing of the cartilage itself. And so these are determining the mechanics of the tissue and what we need to replicate in the biological model.
Got it. Okay. Thanks for clarifying that. It was not quite clear. Switching back to the bone, so the substance that you're creating by itself is a carrier that in itself, this fumarate polymer, this is a scaffolding that will be at least osteoconductive by itself, but it'll also serve as a carrier for other osteoinductive substances. Did I get that right?
Correct. Yeah. So in some of the initial studies, it did not include growth factors. And so it allowed for excellent cell viability and growth just as a scaffold and osteoconduction. And then the goal is to, with increasing porosity, is to incorporate stem cells within it. And then also the other studies had included the growth factors with delayed release. And so it could be something where we incorporate delayed release of growth factors to allow for the graft to get early vascularization with VEGF, and then go back later and inject cells later, which if they're already vascularized, they may survive. So we've actually been using the masculine model in rats as well, looking at femoral defects and seeing if we can condense that down to one step. And that probably somewhat recapitulates how posterolateral fusion occurs, where you get a periosteum that grows around your bone graft, which is probably what the masculine membrane is. And then once that's developed, you have nice vascularity and growth factors, so you can inject cells and end up with a healed bone.
How are the mechanics of this kind of a new era click on cement, which I think is a fantastic title. So one previous substance that was widely used was Norian. It's a hydroxyapatite calcium phosphate conglomerate, tricalcium phosphate. That was very weak in shear, for instance. It had good compressibility, but it was zero in rotational or translational forces. So how does this cement compare in terms of axial loading, but also then the shear components?
Right. So we haven't done as much shear testing. Mostly has been working on developing the compressive properties, and then working on the viscosity to have more control over the viscosity. And because that was one of the major problems with Nurian, was the viscosity was so low, it embolized very easily. And so you have to have something that's easy enough and has low enough viscosity to inject it without much pressure, but high enough viscosity that's going to stay where you want it.
One question came from our audience, and that was exothermic reaction of PMMA. So all of us fear the embolization of PMMA. And one thing that we see, the more high precision CT scans we get, the leakage rate is 80% plus probably. The closer we look, the more we see something leaking somewhere. And we frequently, just the other day in a different case, we saw some PMMA actually having percolated, not visible on the CT, on the intraoperative fluoro, into the canal. So how come we don't have more neurologic damage when we have this highly exothermic PMMA set in the spinal canal?
Well, I think a lot of that's going on during the initial cross-linking reaction. And so usually when we inject it, it's not at that 90°C temperature. So it's cooled down a fair amount before it goes on to harden, and it still has some viscosity left.
I think that's a great explanation. And CSF flow may actually be protective also somewhat.
Right. Yeah, there's some cooling effect, because we see that with some of the laser ablations of tumors where they're heated up to very high concentrations away from the canal, but the neural structures are still protective. And there's a lot of insulation from the CSF.
Well, I thought this was just tremendous. We're at the end of time. I'd love to hear more about it, but you, I think, opened all of our brains and hearts about what's going on out there, and your work is amazing, and your lab is phenomenal with Mike Yazemski, who I worked with in the way past also. So thank you so much for your work, sharing your wisdoms, thoughts, and your clinical know-how also, which was eminently visible during our case discussions. So thank you very much.
Yeah, pleasure. Thanks for having me.